my patient was a 33-year-old G2P0, 23 weeks pregnant. She was sent by her primary OBGYN or whoever because in a span of 4 weeks they did 2 ultrasounds and never saw the fetal stomach. So 6 weeks later, which would be 6 weeks total, they sent her to us at maternal fetal medicine, and we investigated to see if we could find it. The patient's first pregnancy ended in a miscarriage around 6 weeks for unknown reasons, and after 3 years of not being able to conceive, they underwent IVF and became successfully pregnant. The patient had been previously diagnosed with hypothyroidism and was considered morbidly obese. The father of the baby's cousin's child was also autistic, so they did a little bit of genetic counseling there. So that ultrasound that we completed was done. We did a detailed fetal anatomy. The doctor came in behind us, did a scan for himself, and after 40 minutes total, we still did not visualize the fetal stomach. And we also found multiple other abnormalities that weren't noted by her OBGYN. So that same day, the patient had a discussion with the doctor, and they elected to undergo an amniocentesis and sent those results for not only the basic amniocentesis test, but also FISH testing, which I'll explain later. And they also discussed the option of termination. So here are the images. So it was a singleton live intrauterine pregnancy, measuring consistent with the estimated date of delivery. The fetal heart rate and the amniotic fluid were normal. So you can see here we have a little bit of micrognathia. We have an absent left umbilical artery, 2-vessel cord. We have the absent fetal stomach. Just a couple of representative pictures. This one's showing that there's not a diaphragmatic hernia. Here we have no evidence yet of an anal sphincter. Sometimes it's hard to really see the fetal anus on ultrasound, but the doctor was just showing that at this point we didn't see it. And then we have a little bit of hemi vertebrae, which I'll explain later. This picture's a little better. So I'm going to go ahead and skip to lab results. So the patient underwent the amniocentesis, and the samples were sent for the FISH testing, the abbreviated chromosomes, and a prenatal SMP microarray. The FISH testing assesses for, specifically for chromosomes 13, 18, 21, X, and Y. The amniotic fluid, AFP, was also assessed for fetal abnormalities. An elevated AFP would indicate an open neural tube defect, omphalocele, gastroschisis, congenital renal disease, esophageal atresia, and other conditions concerning fetal distress. A drop in the AFP could be a sign of trisomy 18 and 21. The FISH testing stands for fluorescence in situ hybridization, and is a test that maps the genetic material of the individual cells. It checks for those chromosomal alterations that may cause a genetic condition or anomaly. And sometimes those chromosomal alterations are too small to detect with just karyotyping, so the FISH testing kind of is a better testing for that. So the lab results for this patient all came back normal. Pretty much all showed that it was just a normal male. So the lab results were revealed to the patient and her husband, and the doctor discussed the future outcomes. He made sure to tell them that even though their baby may survive birth, that it's going to undergo a lot of surgeries and procedures to kind of fix these abnormalities. And so after discussing their options, the patient opted to terminate the pregnancy. So here I'm just going to throw out a little bit of information and statistics for each. So micrognathia is severe hypoplasia of the mandible that presents as a small chin when imaging the fetal profile. It can cause the fetal tongue to be displaced superiorly and posteriorly, which can cause airway obstructions. It can also cause polyhydramnios. It is either inherited or caused by a genetic mutation. Prognosis depends on its association with certain anomalies or syndromes, arising complications with fetal breathing or swallowing, how early it was diagnosed in pregnancy, and ongoing monitoring and the choice of treatment. The prognosis is very poor when it's associated with pulmonary hypoplasia. It's diagnosed with the appearance of a small chin on ultrasound, which is the most popular, or some radiologists or doctors like to measure the mandibular width from the mentum of the mandible to the bisection of the lateral width line. And that's compared with the gestational age and the BPD. A single umbilical artery occurs in about 1% of singleton births and more frequently in twin births. It's caused by atrophy of one of the umbilical arteries in early developmental stages. An absent left umbilical artery, like in this case, is more common than the right. It is associated with marginal insertion of the cord and membranous insertion of the cord. It's best diagnosed in the transverse view of the umbilical cord, where you see just those two circles, not three. Is most often found in a healthy, structurally normal fetus, so in 80% of the cases. It has an increased risk of intrauterine growth restrictions, small for gestational age, and preterm birth. It's also an increased incident in women with diabetes, epilepsy, preeclampsia, antepartum hemorrhage, and oligohydramnios. Perinatal mortality due to a single umbilical artery is around 20%, the majority resulting in a stillborn. So absent fetal stomach is non-visualization of the fetal stomach is seen in 0.07 to 0.4% of pregnancies. The fetal outcome is poor in the majority of the cases, going up to 100%. The causes of this include esophageal atresia or tracheoesophageal fistula, a diaphragmatic hernia, facial cleft, and a central nervous system disorder, or some type of swallowing disorder. Esophageal atresia is the most common, as you can see with the statistics. And this is what our doctor assumed was the case with this patient. Esophageal atresia occurs in 1 in 6,000 births, or 1 in 2,500 live births. It is discontinuity of the esophagus with or without the connection with the trachea, which is the tracheoesophageal fistula. The maternal risk factors include long-term exposure to contraceptive pills, hypothyroidism like our patient, and diabetes. Sonographic markers include a small or absent stomach, polyhydramnios, and the pouch sign of the esophageal blind end, which would look like an anechoic area in the neck area. It is associated with esophageal atresia. Single umbilical artery is associated with esophageal atresia. More than 90% have the tracheoesophageal fistula. And a fetal stomach still can be seen with a tracheoesophageal fistula. It'll just be small. Perinatal mortality is around 21%, primarily due to associated anomalies. And the prognosis is generally good, but it's good with a prompt surgery after birth. Anorectal atresia occurs in 4 in 10,000 births. It is characterized by the absence of the anal sphincter, or may even have a fistula connection between the anus and either the urethra or vagina. Sonographic markers include a dilated fetal intestinal loops with fluid inside the lumen, a U or V-shaped segment of the distal bowel in the lower abdomen or pelvis, separated from the bladder with mild ascites, and interluminal polylytic calcifications. The absent echogenic spot at the level of the perineum is another sonographic finding, which is what the doctor was really looking for in that image that I showed you. And poor prognosis is associated with associated anomalies, but it's good as an isolated finding. Hemivertebrae is the unilateral aplasia of the vertebral body that can cause congenital scoliosis. It results in a laterally based wedge vertebra with half of a body, single pedicle, and a hemilimina. May be isolated or occur in multiple areas of the spine, the most common being mid-thoracic or lower lumbar. It occurs in 5 to 10 out of 10,000 births, and the prognosis, once again, depends on its association with certain anomalies, and isolated cases carry good prognosis. So, associated anomalies. Micrognathia is divided into 3 groups: chromosomal anomalies, skeletal dysplasias, and primary mandibular disorders. In 40% of the cases, it is a isolated finding. It's also associated with chromosomal abnormalities in 66% of cases, and other associated syndromes are cleft lip and palate, Stickler syndrome, Beckwith-Wyman syndrome, and hemifacial microsomia. A single umbilical artery is associated with congenital anomalies in 20 to 50% of cases, the most common being MSK, genitourinary, cardiovascular, GI, or CNS. There's an increased incidence of intrauterine growth restriction and preterm labor and perinatal mortality. There's also an increased incidence of chromosomal abnormalities, including trisomy 18, 13, 21 Turners, and triploidy, trisomy 18 being the most common. An absent fetal stomach, in the majority of cases, is associated with certain anomalies, most commonly esophageal atresia, tumors of the pharynx, esophagus, or mediastinum, Borner, diaphragmatic hernia, intrathoracic masses, disorders of the swallowing system, or neurogenic disorders of the swallowing system. So the most common reason for an absent fetal stomach being esophageal atresia, 64% of the cases have associated anomalies, most commonly the Bacterol. Also associated with aneuploidy, Down syndrome, anorectal atresia, trisomy 18 and 21. Anorectal atresia is also most commonly associated with the Bacterol syndrome. It is also associated with esophageal atresia and caudal regression syndrome. Hemivertebrae can be associated with cardiac, GI, renal, facial, extremity, and cranial anomalies. Approximately 1/6 of the patients have associated anomalies unrelated to the skeleton and spinal cord, and it has also been reported with an association with the Bacterol syndrome. So treatment. Micrognathia. The majority of the cases are corrected naturally during growth. However, if it's a severe case or if it's having an issue with the respiratory system, swallowing, they'll probably do surgery. And common surgeries are mandibular distraction osteogenesis, tongue-lip adhesion procedure, and a tracheostomy. Micrognathia can interfere with feeding, so sometimes you have to go to therapy or develop special feeding techniques or use special equipment. It can also cause abnormal tooth alignment, so an orthodontist is often seeked. Hemivertebrae. So when a chromosomal anomaly and open neural tube defect are ruled out via an amniocentesis, the first concern is ensuring a safe labor and delivery. The fetus is monitored throughout pregnancy for growth, any new signs of an open neural tube defect, and for associated cardiac and genitourinary anomalies. After birth, the child is continuously monitored for congenital scoliosis or the degree of scoliosis if it's already found. And if this occurs, hemivertebrae excision is performed to remove the abnormal vertebra and allow adjacent portions of the spine to grow normally. In more severe cases, a growth rod procedure, spinal fusion, or reconstruction of the spine may be necessary. An absent fetal stomach. So in cases where a chromosomal anomaly is ruled out, esophageal atresia is normally assumed to be the primary cause. If the fetus survives to birth, the diagnosis is confirmed and surgery is planned. They are first tested to see if it is a tracheoesophageal fistula, and in that case, that passageway is closed off before the esophagus is surgically connected to the stomach. Single umbilical artery. There's typically no treatment for this. However, throughout the pregnancy, the fetus is monitored with ultrasound for intrauterine growth restriction and adequate blood flow to the heart and the brain. And when there's no evidence of an anal sphincter, anal rectal atresia is normally assumed to be the cause. It is not until after birth that this is confirmed, and after birth the testing is done to confirm that this is either an anal rectal atresia or an infant anus. And regardless,